You're watching Ready or Not. What is motivational interviewing? Part 2. Behaviour change approaches for smoking cessation in general practice. Produced by GP Supervision Australia and presented by Dr. Eileen Cole and Dr. Sasha Filia. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced and pay our respects to their elders, past, present, future, and their families.
My name's Simon Morgan. I'm a medical educator working with GPSA. I'm joining you from a Wabakal country. And it's a great pleasure to reintroduce our two speakers. Eileen's the GP lead for QUIT, based in Cancer Council Victoria. And Sasha is a cessation advisor with QUIT Centre, working in the same organisation. They've both done loads of education over their work with the Cancer Council Victoria. And it's a great thrill to have them along, particularly with that focus on supervisor education. The learning objectives are next, and really this is a bit of a discussion between the team and myself, very much around supervisors teaching registrars about motivational interviewing, and particularly through the prism of smoking and vaping cessation.
Thanks very much, Simon, and welcome everyone. We ended off with some requests for role plays. And the purpose of the role play is really to put into action how you can implement brief advice in your practice to help support people who are smoking and vaping to quit. And the whole purpose of brief advice is that it's a short conversation between a health professional and their patient that connects the patient to best practice cessation care, which is a combination of behavioural intervention and pharmacotherapy if it's clinically appropriate. So we've got 4 short videos, they're of just over a minute each, trying to implement the Ask, Advise, Help.
Well, Laura, that's great. Your blood pressure's come down nicely, and I think we've got medication worked out really well. So that's fantastic. Let's see. So I can smoking. Can you tell me, have you still I did quit. I quit for about 6 months. Yeah. But in the last 3 months, I started up again. And that's mostly due to the stress that I'm feeling at work at the moment. Yeah, okay. So can you tell me a little bit more about your smoking patterns at the moment? Yeah, sure. I just, went through a really stressful time at work, and I find that being able to pop out and have a cigarette really helps me. Yeah, it gives me a bit of a break so I can relax. Yeah. And I also enjoy having a cigarette with the coffee in the morning, so it's just something that I really am enjoying. Yeah, okay. And what was quitting like for you? Quitting was really quite challenging, actually. I quit cold turkey, and I found, especially in the beginning, that I was getting really grumpy and really easily irritated. I did stick it out, like I said, I did quit for 6 months, but yeah, I have started over. Well, I think it's fantastic that you've been able to quit, because quitting smoking can feel really overwhelming, and it's quite common for people to need to try more than once to be able to quit in the longer term. Yeah, I know that I should quit. I just don't think that I can do it right now. And, I know it's bad for my health. My partner wants me to quit, but I just can't imagine how I would go through it all again and also cope with the stress that I'm feeling at the moment. Yeah, I can understand being quite stressed at the moment. It might help for you to be able to think about the benefits of quitting for you. In particular, reducing the risk of cardiovascular disease. Even though you have high blood pressure and we're managing that, stopping smoking is definitely the best thing you could do to lower your risk of things like heart attacks or strokes. Yeah, it's just not something that I can think about in the moment. I think about the fact that it's helping me to feel relaxed. I don't really think about the longer term health. Yeah, benefits, even though that I know logically that, I can benefit from it. Yeah, I understand that. Quitting smoking is really beneficial for your mental health as well. And people report that after 6 weeks, they actually feel less stressed, less anxious, and less depressed. Yeah, okay, I didn't know that. No, that's right. So it's something that may help you in the shorter term. But actually, the best way to quit is using a combination of tailored counselling, so that's individual counselling to support you, as well as using medications to help manage the withdrawal from nicotine and the cravings that you might experience. Would you like to talk about these a little bit?
Sure. Yeah, sure, that sounds good.
Quitline is a telephone counselling service, and I can arrange a referral today if it's something you might be interested in.
Okay, so what exactly happens when you call Quitline?
Okay, you and the Quitline counsellor will have a discussion about smoking and what smoking means for you, and also things that may be triggers for you or induce cravings. And once you've had that discussion, you work together to make an individual plan that's just for you about how you might manage those things and how you can quit.
Okay, that sounds good. Yeah. Does it cost anything?
If I make the referral, which is quick and easy, we can do that today, there'll be no cost to you. The Quitline counsellor will call you, and then you make a plan together, but subsequent calls after that.
Okay, that sounds good. And then what about the medications that you mentioned earlier? Do I need to take those still?
Well, the medications can be really helpful, in particular for managing your withdrawal symptoms and cravings. Withdrawal symptoms are most severe usually at the beginning, in the first week or two. And so the medications can help to minimise those symptoms. The types of medications that are available are either nicotine replacement therapy, which can be patch form, as well as other forms, and also some oral medications or tablets that you can take daily. And we can work through which of these might be best for you if you'd like to chat about that, and it'll get you started.
Okay, sounds great.
Good for you. I think this is fantastic. This is the best decision that you can make for your health. And I'm here to support you through your quitting journey.
I just don't think it's something I can take on right now. There's so much going on in my life. I'm really stressed at work and I just don't want to go through the whole thing again.
Okay, sure. Just please remember that there is help available. Quitline's a telephone counselling service, and they can be really helpful, and they can even prepare you to make a harder quit attempt. And also there's medication available to help you with those withdrawal symptoms.
I just really don't think that it's the right time for me.
Absolutely, okay. Well, remember that I'm here to help you and I can support you. And is it okay? I might check in with you again at the next visit to see how you're travelling.
Yeah, sure, that's fine.
Sure. In the meantime, would it be okay if I gave you some written information to take a moment and read?
Yeah, sure.
Okay.
Jim, who's an older person, and then we'll move on to Sam, who's a younger person. And so you meet Jim in your surgery and you haven't seen Jim for a long time. He's 55. He's coming to you reluctantly because he's recently been to ED and he's been told that he needs to have some surgery. So you've got the discharge summary for Jim and you request that he comes in to have a chat about what's been happening. And you know Jim, but he attends very, very infrequently. And he's come in this time because he attended ED and had treatment for an episode of cholecystitis and he needs to have surgery. And he's not in great shape at the moment. He's not taking any medication and he's been smoking 30 cigarettes a day since he was 15. And also he drinks beer and whiskey every day. And he tells you, don't tell me to stop drinking and smoking, doc, but I don't know how I'm going to cope in hospital. I know you're not allowed to drink and smoke in hospital. I'm not sure what I'm going to do. And you catch up with Jim because you haven't seen him for a while and you know that he's married and you know that almost everyone in Jim's life either smokes or vapes. So his wife smokes. Most of his colleagues at work in the concreting company smoke, and although some of the younger people also vape. And then he likes to socialise at the footy and going to the pub, and most of his friends in those social circles smoke as well. So stopping smoking is not on his radar. He's never been able to really stop smoking for more than a day in the past. So you know that you need to offer help to Jim to be able to support him stop smoking. And you know in the back of your mind that there's a little bit of ambivalence at the moment because he sees that there's a need for him to make some behavioural changes before he heads into hospital. So of the suite of options that we've got to help Jim, we can offer him some self-help tips and we can potentially use some motivational interviewing. And this is going to be important for Jim because of that need to change behaviour to go to hospital. But also, based on Jim's history so far, we'll have a really sort of low bar for thinking about we're going to need to provide him some more intensive behavioural support and pharmacotherapy. So during the initial consultation with Jim, we do all the necessary things to sort of start investigating a man who's got high cardiovascular and metabolic syndrome risk potentially, and he's now sort of going to be coming into you for a little while. You say to Jim, look, I think while we're sort of assessing what needs to happen before you go into hospital, how about a referral to Quitline to have a chat with some specialists who can support you to think about how you might approach quitting. And then we'll see how things go when I see you in a week for your test results. So Jim agrees to have a chat with the Quitline counsellor, and I'll hand over to Sasha, who'll talk you through Jim's Quitline experience.
Thanks, Eileen. Yeah, so with Jim, Quitline received a referral from him, from the GP, and Jim was called on the same day and was happy to accept a call from Quitline. And the first two calls with Jim were focused on assessment, and they're sort of what we talk about as our pre-quit calls. And in that pre-quit time, when we focus on the assessment with our clients, we spend a lot of time going through general introduction, but also doing a detailed assessment of their smoking behaviour. And with Jim, it became, clear that he'd been smoking for a very long time, 40 years, and the longest time he'd been without a cigarette was about 24 hours. Through the assessment, we found, that he had a lot of people around him that were smoking or vaping, and that was at work, socially. He also was drinking alcohol regularly, and he was experiencing some stress at work. The assessment also indicated that he'd never used any sort of pharmacotherapy to help him with stopping smoking in the past, and that he was around a lot of people that were smoking and vaping, as I said, at work, but also in his household. His wife smoked, and his activities revolved around his smoking as well. With our Quitline assessment, it is a therapeutic assessment, and we really try to focus on providing as much feedback as we can during that assessment phase, because that helps us to move the client into goal planning and planning for treatment. And we do spend a lot of time exploring motivation and confidence with our clients. And just quite broadly with Jim, he sort of, in terms of when we asked about motivation, he said he sort of felt forced to stop smoking because his GP said, he was sent to the GP by the hospital that he had to stop smoking because he was going to have surgery, and he really didn't have a lot of confidence in his ability to stop. So in the spirit of motivational interviewing, some of the focus that we would consider for Jim in going into more detail around looking at his motivation, Quitline will explore, a whole range of different things to try and assess where he's at, but also to help shift and support the client to feel more confident and to be more motivated to make the changes. So with Jim, the Quitline counsellor, through the therapeutic assessment, was able to identify that despite his initial apprehension and comments saying that he sort of felt sent there and forced to have to stop smoking, in fact, he actually did think it was quite important for him to stop smoking. He really did recognise the impact it was having on his health, and that he was concerned about his health for the future. He was also concerned about, the relationship with his grown-up children, and if they were going to start having families, they were very clear that they didn't want to bring their kids around their dad that was smoking. And he did say, yes, smoking is costing myself and his wife and him a lot of money. So he was able to articulate that there were quite a number of reasons, and it actually was quite important for him to stop smoking. But the challenge for him was that he felt that he didn't have the skills and he absolutely did not have the confidence. So that obviously then provided the foundation for where Quitline can support him in that area. And so therefore, with the treatment for Jim, all our support that we provide to clients are tailored for that individual client. So even though it is in the pre-quit stage where we do this therapeutic assessment, we still have the opportunity to provide some psychoeducation as we go along, and also some tailored skills whilst we are doing the assessment. So particularly for Jim, when we think about tailoring psychoeducation for him, what we focused on was just actually normalizing that ambivalence, acknowledging and normalizing that he was unsure. And in fact, many people who quit don't feel 100% ready or sure about it. We spent time talking to him about the relationship between smoking and mood and stress, because that was something that came up for him during the assessment. And we started just to raise the idea with him about pharmacotherapy and talking about different quitting methods, and providing the message that the most effective way to stop smoking for him will be to use quitting medicines and a support service like Quitline, and that, we can support him throughout that stage, and also discuss with him if he chooses to use pharmacotherapy. And then through the assessment, we also started to consider some of the skills that we could support him with, and they were around identifying his triggers and starting to talk about how he might prepare for that quit day, thinking about how he might need to consider changing his environment at home, whether that might be thinking about removing all signs of smoking or where he keeps his cigarettes, starting to prepare to have tools that he might find useful when he gets ready to try to have a quit attempt, and also thinking about maybe having some practice quit time, whether that's a number of hours or half a day. And we then recommended that he would then go off to see his GP again and have that conversation around pharmacotherapy.
So then Jim comes back to see you as the GP to follow up his investigation results and to have a little bit of a chat about getting ready for his admission to hospital. And as part of the follow-up investigation, we have a chat with Jim about what he thought about Quitline and his experiences with the initial assessment and calls, and what he thought about making a quit attempt. And Jim was positive about his experience with Quitline. He felt that the counsellor was very helpful and supportive, and he thinks he might be ready to have a go at quitting. He responds that he's had to think about some pharmacotherapy, and he thinks that he might need it. He's not sure if he'd be able to cope with cravings and withdrawals without using some form of pharmacotherapy. And he'd really like to start that before he has a go at stopping smoking. And the importance of the shared decision-making in selecting pharmacotherapy includes not only the type of pharmacotherapy that you might use with the patient, but when to start it and how it's going to be used, how available it is in terms of cost and access from compared to pharmacy and supermarkets. And important for Jim was that he really wanted to be able to completely manage it himself. He planned to, again, not come to the doctor very often after he'd had his operation, and if he wanted to be empowered to be able to use pharmacotherapy that he could access himself. So when we're thinking about commencing pharmacotherapy for Jim, we need to assess his nicotine dependence to guide our initiation of pharmacotherapy. So nicotine replacement therapy for Jim would be the most suitable option. He was not keen on taking medications, and he can access pharmacotherapy either at the supermarket or at the pharmacy. He doesn't require a prescription, although patches, if he has a healthcare card, he can get some patches on the PBS, which may make them cheaper. But back to being highly nicotine dependent, you can use the nicotine replacement therapy tool, and I'll demonstrate this at the end if we've got time. But at quitcentre.org.au NRT tool, we've got a pharmacotherapy tool which has an inbuilt assessment of nicotine dependence, and then some suggestions for initiating NRT dose, as well as instructions on how to use the different forms of NRT. And if you have time to sit with the patient and go through that, you can sort of have a discussion about how to use patches and have a discussion about the chew and park technique. So Jim preferred to use NRT, and combination NRT can be effective as varenicline when it's used appropriately, and in particular titrating the shorter term pharmacotherapy to clinical effect. So making sure that if a patient's using the gum, the lozenges or the mouth spray, that they use it in anticipation of a craving. So regularly enough to be able to really take the edge off the cravings and the withdrawal symptoms. So we initiated a prescription for Jim to be able to get nicotine patches at 21 milligrams for 24 hours and some gum, which he could purchase over the counter. And he felt this was the most sort of discreet and user-friendly way that he could commence pharmacotherapy. And then we provided Jim with some links about some support to be able to have some demonstration techniques for using patches and gums. And importantly for Jim, we had encouraged him to try and reduce his caffeine as he was reducing his smoking, because the metabolism of caffeine can be changed in people who have reduced smoking and may potentiate insomnia.
So then with Quitline, we continue to follow Jim up, and this just represents sort of the time frame of calls that we provide through the Quitline. And so the timing and content of calls can really reduce the risk of relapse during the quitting journey. And so in terms of the support that was provided for Jim, once he had started to use his pharmacotherapy and had made his quit attempt, we focused on tailoring psychoeducation around that pharmacotherapy. So he had started using that and was using the patch and the gum. And Quitline can support clients by checking in on how they're using those products, seeing if there's any trouble issues with it. And with Jim, he reported that he was using them, but when he was working during the day, because he was doing physical work and he was sweating, he was having some trouble with the patch sticking on his skin. So we advised that he could use some sort of micropore tape around the outside of the edge of the patch. Something preferably waterproof would be helpful. And so he found that really helpful to keep the patch on whilst he was working. We spent a lot of time talking to him about how to manage his triggers for smoking, and we also provided support and education around his use of alcohol and the fact that there is that potent sort of relationship between alcohol and smoking, and the two go kind of hand in hand. Quitline doesn't specifically provide support for people wanting to change their alcohol use as such, but we do have sort of a partnership with Direct Line. We make referrals to Direct Line and other support services if people require assistance with working on their alcohol use. But we do provide that psychoeducation that it is beneficial to try and tackle both things at the same time, that the research shows that if you can focus on smoking and alcohol at the same time, you have better outcomes for both. In terms of focusing skills building for Jim, the main area for him was the fact that he was really around many people in his environment at home and at work that were also smoking or vaping. And so, in the spirit of motivational interviewing, we started off by asking him, what do you think you could do when other people around you are smoking? And he was a bit stumped at first, and so he sort of had some ideas, but when it was clear, he was sort of trying to struggle to come up with other things, we asked, would it be okay if I shared with you some things that other clients do in this situation? And we presented a whole range of options to him, which I will go through a few of those. But then, asking, how might that work for you? Is that something that you could try? So again, just in that spirit of motivational interviewing. So for Jim, in terms of where we focused on skills building for him, it was a lot to do with being in the home where his wife was also smoking. So it was about having that discussion around what sort of support he thought his wife could provide in this situation, just having that open conversation around how they were going to manage when she was going to continue to smoke and he wasn't going to smoke. Quitline can also provide support to family members of clients as well as interested relatives. If they would like to call Quitline, we can provide information on how you can support your family members or close friends to change smoking. So that is important to note. And we talked to Jim about how to manage that physical environment if one person is still smoking and he didn't want to smoke. So whether it's about negotiating with his wife around, could they maybe make a designated smoking area in the house, keeping that to a minimum, or whether she was comfortable to go outside to smoke, like having that discussion and supporting Jim through that conversation with his wife. And obviously encouraging him to make use of the NRT regularly, but also to ensure that he's using the short-acting NRT in anticipation of triggers and making sure he has that with him whenever he needs it. And in terms of other situations for Jim, particularly around work, he was around a lot of colleagues that smoked and some of them that vaped. So because his work is outside, we talked about, they would go off and have smoke outside. We talked and discussed with Jim, what else he might do during those times. And because, he was outside and it was hot, and he sort of came up with the idea that maybe during his break, maybe he could go inside for a little bit and have his break inside and sort of have a change of environment and not be around the other people who were smoking. And also talking to him about in his work environment, were there any people that, could support him in not smoking, and reminding him about the importance of carrying his pharmacotherapy, his short-acting NRT, taking the gum to work, keeping it on him, using that regularly throughout the day. So then also socially, talking about when he was going to the footy or when he was going to the pub, spending time talking to him about those situations that may be high risk for smoking and how he could prepare and plan for those situations and what he could do to work to not smoke and think ahead, of the other things that he might be able to do or change his routine a little bit whilst he's sort of getting a few days under his belt without smoking.
Other helplines that are provided by pharmaceutical companies, is Quitline a government service?
So Quitline throughout Australia, the different Quitlines in each jurisdiction are funded by Department of Health, and some are funded by the Cancer Institute and cancer councils. So they're all a little bit different, but with the background funding of Department of Health, but individual state Department of Health. So it's not run by the Commonwealth as such.
Yeah, that's right. And they're not pharmaceutical companies involved.
No funding, no provision of NRT, nothing like that. Yes, no, not from anything related to pharma.
Curious to know what about the pros and cons of non-patch NRT. Why gum over lozenge over inhalator? So the 4 shorter acting forms of nicotine replacement therapy are gum, patches, lozenges, and the inhalator. And it's really looking at the person in front of you to be able to help them decide what they're going to use. So if people have a very dry mouth, then you would not use the lozenges. If they had dentures, you may be not so keen on using the gum. If they felt like that they had difficulty managing their cravings, then you may be looking at something a little faster acting like the mouth spray, which is the fastest acting form. But if people had arthritis and dexterity issues, they may struggle with the mouth spray and the inhalator. So it's looking at a combination of the factors for the patient and how quickly they need to get the shorter acting form to work. All the shorter acting forms, especially the gums and lozenge, people with reflux might notice that they can struggle if they're swallowing too much nicotine. So all the nicotine in the shorter acting forms is absorbed through the buccal mucosa. So you need to make sure that patients aren't eating and drinking too much around the time they're using their shorter acting forms, and try to avoid swallowing, especially the gums and the lozenges, letting the lozenge dissolve slowly by rolling it around from side to side, and using the chew and park technique for the gums. So chewing it until it has a peppery taste and then letting it sit between the skin of the mouth or the lining and the lower gum to be able to let the nicotine absorb. So we were happy that Jim was able to quit before his surgery, and he felt comfortable using his nicotine replacement therapy during his hospital admission. It was supplied for him on hospital admission, so he felt comfortable, and the surgery went well. And during follow-up after his discharge, it was really important to continue to offer support for Jim to prevent any relapse, because relapse rates are a real risk once that acute urgent motivation has disappeared. Sasha, could you tell us a little bit about the kind of feedback that, as a GP, we can expect to get from Quitline?
Yeah, sure. So when we receive a referral from a health professional, at the end of our involvement with our client, we provide a letter back to that referring health professional, and we summarise the contact that we've had with the client, the main outcomes, if they've used pharmacotherapy, and we provide a detailed summary back just like you would receive from any other specialist that you would refer to. So it's really useful to have that summary, and we think that's a really helpful thing for GPs to receive, or whoever the referrer is to receive. So to get that sort of full comprehensive service and see where things finish in terms of our contact with the client.
Thanks, Sasha. That's great.
I just very quickly, Sasha, how long is that pre-quit session the one that you describe with
Yeah.
Jim? Because it sounds very comprehensive. Is it 30 minutes, an hour? What sort of time frame we're talking?
Normally, our pre-quit assessment calls are generally split over 2 calls, probably of around 20 to 30 minutes each call. We try not to make our calls any longer than that around the assessment, because obviously it's hard for the client as well to concentrate. So,
really, in reflecting on this, it struck me that that's not something that's been my practice, and maybe that of others, that, it's often here's the NRT and here's a referral to Quitline, but that kind of pre-quit counselling session to set things up sounds like a really, really powerful tool. So something I'll start doing.
Next, we'll move on to Sam, who's 19. And Sam comes into your clinic wanting a medical certificate because he's got a headache and he's not feeling great. He hasn't been sleeping well and he thinks he might have a virus and he can't go to work in his part-time job at the supermarket. And you chat a little bit to Sam about what's happening for him in his life, and he tells you that he's at uni, he's moved to town and he's living in a share house. He's had to leave home and his family to be able to come and study at uni. And he's sort of okay in the share house. He likes to sort of hang out with people. They have a few drinks and everyone else in the house vapes. But it's clear during the consultation that Sam's not feeling great, that he's really worrying a lot. He's missing home. He's ambivalent about his course and he's just really feeling that he's not sure if he's done the right thing and he's not sure he might move home and he's really quite anxious. So we know that Sam's told us that everyone in the house is vaping and that he's in a new environment with a behaviour change. So we use the Ask, Advise, Help model to say to what's happening for you, Sam? Are you vaping at the moment? And Sam tells you yes, that he is vaping at the moment. And so you sort of suggest to Sam that it might be great to, if he could look at stopping vaping as something really positive that he could do for his health, and that you can definitely help him to stop if he'd like to do that. And the range of options that you've got, again, the options for Sam would be to offer him some advice, some practical printed information. You could offer him My Quit Buddy. You can provide motivational interviewing. But you want to sort of take a little bit more of a history and work out which options are going to be right for Sam at the moment. So you initially, when you examine Sam and you find there's nothing physically going on for him at the moment, you provide him with a medical certificate. You really stress that, you can hear that things are not going well for Sam at the moment. You'd really like to see him again and understand things a little bit more, potentially look at his mental health, and you think it would be great if he would be willing to have a chat with Quitline, who can support him to think about changing his vaping. And Sam says, great, he'll come back and see you again. And he's quite happy to have a chat with Quitline. Once you've reassured him that Quitline is for young people, it's not just for old people, and it can be helpful for people who are vaping to quit as well. So Sasha, how would, acknowledging that Sam has potentially some mood or mental health related issues and he's young and he's vaping, not smoking, what is this Quitline different for Sam than it would be for Jim?
Yeah, so we'll highlight the sort of differences and what Quitline offers to young people who are vaping with some sort of mental health concerns as well. So with Sam, the first 2 calls being our therapeutic assessment really focused on engaging and conducting a really comprehensive assessment of his vaping. So for Sam, we learned that he was in first year uni and he had started vaping in his first year at uni, sort of infrequently at first, just a couple of times a week, but that was now vaping daily, and then decided to purchase his own vape a few months ago. And he didn't really think that it contained nicotine, and that he kept it with him all the time, even slept with it under his pillow. It was always on his person. And he reported that he did struggle during long classes at uni, not being able to vape, and occasionally he'd take us a sneaky sort of puff during the lecture, but it was a big challenge for him to get through a class without vaping. He said to us that, the GP thinks I should stop vaping, but I'm not really sure. I don't really think it's a big deal. And when we explored with him what he liked about vaping, he said that it made him feel good, sort of made him feel calm. It was something he liked to do with his friends. He noticed that it had helped him concentrate when he was studying, and he said he liked the taste. He particularly liked the fruity sort of tasting vapes, and that was something he did enjoy. And when we asked him about what he didn't like about vaping, he commented that it can make him feel weird if he did a lot of vaping. So he sort of said that he would feel a bit dizzy, have a headache, like he was going to vomit. And then he commented that it was getting harder to find and it was getting more expensive to buy.
Sam's had his initial chat with Quitline. He's had his initial assessment. In the interim, he's come back and he's booked a long appointment because you've said, look, we might do a mental health care plan and see what support we can get for you. I've jumped the gun because we haven't made a formal diagnosis, but assuming that we had longer in the first assessment. So as part of assessing Sam's mental health, we really need to understand, well, first of all, did he like Quitline and did he see that this was going to be helpful? And understanding his nicotine dependence is going to be really important to help us work out what kind of support we're going to need to offer for Sam. And in young people, so especially those under 18, we use either the time to first vape and the MHONK, which is a sort of a broader questionnaire than we use for older people, to help the younger people reflect on their vaping and to get an idea of the level of nicotine addiction. This is one of a number of tools that can be used in young people. And the challenge with assessing nicotine dependence in vaping is that it's not as straightforward as it is for smoking. So if we're only going to rely on one indicator, it would be the time to first vape. If young people are waking up and it's the first thing they do in the morning, or they're waking up during the night to actually vape, there's a high chance that they have high levels of nicotine dependence. And this is a long conversation we could also have later as well. So we know that really for Sam that he's going to need support from a mental health and social perspective, given that everyone else in the room in his house is vaping, but also because he is nicotine dependent. We'll think about what pharmacotherapy would suit him best. And recommendations for young people and for using pharmacotherapy for vaping cessation. The evidence is still not, we don't have long-term evidence to help guide us like we do with smoking. All the guidelines, the current Australian guidelines recommend that we use what we know applies to smoking and translate that for vaping while we wait for the evidence to come through. So we know a nicotine replacement therapy can be used for young people from the age of 12. And what was really important for Sam is that it was discreet, that he wasn't super keen on anyone knowing that he was needing to use nicotine replacement therapy because he didn't feel great about the idea that he might be nicotine dependent. So he was really wanting to make sure that no one would know and that he used it only when he thought he needed it. And the other important thing was to get him some mental health support, so linking him in with the University Mental Health Service. So as I said before, if he's highly nicotine dependent, because of his first vape on waking, we decided that we'd use a nicotine lozenge, which he was going to purchase over the counter, and he could buy that at the pharmacy or the supermarket. We provided him with some link where he could get some video information about using the lozenges. And we suggested that he might use the My Quit Buddy app to help support him and encourage him to engage with his vaping and really think about what was happening for him as he attempted to quit.
So in terms of the focus of our behavioural support for Sam with the Quitline, one of the areas that we offer for clients who report experiencing a mental health condition or any concerns around their mental health is the option of mood monitoring. And so as Quitline, we provide a tool that we use, and we call it the Moods and Experiences Scale, which is based on the Minnesota Nicotine Withdrawal Scale. And research has shown that monitoring nicotine withdrawal and mental health, as well as medication side effects for people who are taking medication, can help us to distinguish what may be temporary withdrawal symptoms from symptoms of mental health. And that can also help us to facilitate targeted treatment to help clients who experience mental health symptoms to manage particularly the acute phase of nicotine withdrawal. And so it's also really a very powerful monitoring tool for the client for their experience, because we know that monitoring and providing feedback, which is what we do once we go through the scale, it is quite a powerful behaviour change technique, and it's shown to be very helpful for this client group. And so with Sam, at each Quitline call, we asked if he had experienced any of these experiences over the last 24 hours, and then we would rate them mild, moderate, severe. And we provide feedback at the end of each call. So, last time this is what you rated, this is how you're going at the moment. And with him over time, we did notice that his reported feelings of anxiety had started to reduce and he was feeling less restless. And then in terms of the other areas that we focused on for behavioural support for Sam was spending that time with him, particularly around tailored psychoeducation, around, discussing the content of vapes. So I think this is a common thing that we hear, particularly with young people. They have purchased vapes, however they have, and assume that there is no nicotine in them. But, we talk to them and we try to do this in the spirit of motivational interviewing by asking first, whether it would be okay to share some information with them. And we talk to them about the research that we know is out there, that in fact, many of these vapes have been tested, and in fact over 95%, 96% plus actually do contain nicotine, even if they're labelled as non-nicotine. So we do talk to clients around, and this was a focus for Sam, and sort of providing that information to him around what nicotine withdrawal symptoms look like, what he might be experiencing, and connecting the dots with him that he realised, yes, in fact, this must contain nicotine because I am experiencing nicotine withdrawal. And we talk about the stress nicotine cycle and how, that concept of nicotine withdrawal, alleviating that nicotine withdrawal by vaping more seems to be relieving the stress, but then it's actually reducing the withdrawal, and it's that vicious circle. So we talk about how it's in fact relieving nicotine withdrawal, not making vaping that's reducing their stress, and focusing on that conversation around pharmacotherapy and encouraging Sam to continue to try using the lozenges. With him, we spent a lot of time talking about skills building because, he had quite a strong attachment to the vape. It was always with him. And as we hear with young people, it's that sense of anxiety, that sense of urgency about like not knowing where the vape is or being apart from it. So it was almost like a graded exposure thing to try and start small times being separated from the vape, leaving it away from them. So with Sam, he was comfortable to consider trying that at uni. So maybe leaving it in his bag rather than having it in his pocket. And that was something that he was working on, keeping the vape in his bag longer to have greater periods of time without vaping whilst he was at uni. Obviously, the importance of taking his pharmacotherapy, his lozenges with him to uni. And we acknowledge that it was really hard for him to continue in the household and interact with the people that he was living with who were vaping a lot. And that was the way that they sort of hung out and bonded together. So, that was still a work in progress for Sam, but he was being more aware of how much time he spent vaping at home. And, because as Eileen was saying, he wanted to be discreet about his use of the lozenges. He also sort of didn't want to make a big deal that he was trying to stop until he sort of felt more confident. But if everyone was vaping in the house, he'd sometimes decide to go for a walk instead, or he'd try to maybe, retreat to his room and do some studying. So he was trying to limit and minimize the amount of time that he was sort of doing that, but acknowledging really challenging, really tricky. And just in terms of getting some support with stress management and encouraging to use the My Quit Buddy app. And the other thing that we discussed was in terms of being at uni, he liked the fruity flavored vape. So had the discussion around trying some sort of sugar-free lollies that were fruit flavored and keeping them with him and having that during the day at uni instead of having the vape, and sort of alternating between the sugar-free fruit flavored lollies and his lozenges. So these were kind of things that he was happy to try and was finding useful.
So when we caught up with Sam again in the general practice, it was important that we continued to offer Sam support. So he wasn't able to quit vaping. He was definitely aware of his vaping behaviour, and he was making efforts and attempts to reduce vaping. And the other thing that we felt was really important was that we linked him in with support services that were available and tried to improve his mental health to a point where he felt that being able to quit vaping completely would be much more on the cards. And we reassured him that he could stay in contact with Quitline. He actually really liked having that one-on-one support and being able to have a discussion with a counsellor, and using that in combination with other local support services and staying in contact with you as the GP sort of put Sam in good stead to be able to make another quit attempt in the future. So that's all we have from the point of view of the cases. So I think Sasha's already answered the question of, do we know if vapes contain nicotine? We definitely know that even those that are unlabelled contain nicotine. In fact, there's some really good online videos, a recent one from the University of Wollongong, and I'll find that and see if I can share that, about the chemical composition of vapes. People may have seen that. And the number of chemicals that are actually in a vape can be quite astounding. I think that forms the basis of our unknown. We don't know the long-term impacts. There's a lot of controversy and discussion about, is vaping safe or is it less harmful? We agree that for all young people, and especially for people who've never smoked, that vaping is not something that we consider that they should be doing.
One of the conversations we had was around quantification of nicotine dependence, or attempted quantification in vaping. You were saying, Sasha, it's actually incredibly difficult, if not impossible, to get a sense of that from people's use of vapes. Is that MHONK scale and the time to first vaping a reasonably useful measure then?
Absolutely. And that's what's recommended in the RACGP guidelines. So it is all outlined in the guidelines too. So it's a good resource to have a look at in terms of, vaping assessment.
So how long, Sasha, can somebody remain with quitline?
Yep. So we don't have an end date. Obviously, we have our sort of structured calls during the quit process, so if someone is following that quitting journey and then does quit, then, we have times where we follow them up, and then generally 30 days after quitting, and we tend to sort of stop follow up then, but it's not like you get kicked out. You can continue to call in. You can call in again if you return to smoking or vaping. You can call in as many times as you need to. We don't have like strict rules around that, obviously within reason.
A couple of things have really changed my practice, I think, and that would be harnessing the value of that pre-quitline counselling session prior to my role as a prescriber of NRT or some other medication, and also using quitline for vaping. I just had not really made that connection, and to think that's a really good resource. The question about bupropion and its role in the armamentarium of pharmacological therapies for smoking cessation.
So bupropion it has a role. It's an antidepressant that was found to be useful for smoking cessation. It's not as effective as varenicline or combination NRT. And in terms of effectiveness, it's similar to single formulation of NRT. And people would consider using it instead of varenicline. I know there was a fear about using varenicline because of the potential for serious psychiatric potential outcomes and increased suicidality. But since that time, we've had the EAGLE study, which has come out, which has confirmed that varenicline is safe to use in people with serious mental illness. And this is an area of Sasha's expertise because she's worked with people with serious mental illness. So, Sasha, do you want to go ahead?
Yeah, I was back many years ago very unsure about varenicline when it first came out too, but I can vouch that we have used that medication in people with very severe mental illness, chronic, schizophrenia, bipolar disorder, very unwell, and it would be the only medication that had enabled clients with such severe mental illness to actually stop smoking. I'm talking people smoking 40, 50 cigarettes a day that had tried other things. So, my confidence in the suitability of that medication, obviously within a well-supported, monitored, lots of follow-up, but really, really, good option for clients who, I wouldn't exclude people with severe mental illness. Obviously, they hopefully quite stable, but doesn't mean that they have to be completely symptom-free.
And the College of Psychiatrists guidelines reinforce that. They've released their guidelines as well, and they recommend that, mood can change in people who are with serious mental illness. So it's really important to continue the follow-up.
And I think last week, Eileen, I sent you a news story from one of the weekly medical rags that was talking about cytosine coming along as another medication we could use. What's cytosine and where will it fit?
Yeah, so there's cytosine and cytisinicline, which are similar in activity to varenicline, that they act as a partial agonist of the nicotinic acetylcholine receptor. So they're a potential new option, and there has been some scheduling decisions on cytosine as S3 and S4 entries, and these scheduling decisions will be applicable from the 1st of October. But again, they're not any ingredients that contain cytosine, or any medicine that contains cytosine as an ingredient is still not listed on the ARTG yet. So they're a potential option that have the potential to work like varenicline does, but their dosing schedule is a bit more complicated and not set yet. It's been used in Eastern Europe for a long time, plant-derived. Yeah, so potentially will have a role. It's promising as an option. Side effect profile is maybe a bit not severe, but a bit more diverse in the types of side effects that people might experience. And it will be the dosing schedule, but it's a reducing dose rather than an increasing dose. And it involves taking, up to 6 tablets on the first day and then reducing down over 25 days. So yeah, it will be, let's watch this space, but it's good. It's exciting to have something else available.
Question or comment about the difference between Nicovape and inhalator, or maybe just vaping and the nicotine inhalator, but I'm guessing the mechanisms of delivery are very different.
Yes. Yeah, so the inhalator has nicotine that's absorbed in the buccal mucosa. So you actually puff on it.
Yeah.
And you're not inhaling it into the lungs, whereas vaping includes completely different ingredients. So you've got vegetable glycerin and BG and PG, glycerin-based, and then you have the flavorings, and then you have the nicotine, and so it's completely different. Yeah. Much higher levels of nicotine in a vape than you can actually achieve with an inhalator. So especially for young people, that rapid hit has much greater potential for addiction, whereas an inhalator is much lower dose. So you just don't get that big spike.
And are we seeing much of that acute lung condition that was early described in vaping? EVALI, is it?
Yeah, we think it's underreported. So at the time that EVALI was reported as an epidemic in the US, it was thought at that time that it was an acute lung injury, like an acute respiratory distress syndrome or an organising pneumonia, which was related at that time, they think, to a vitamin E acetate that was added to some of the cannabis oils. But we think now vaping-related lung injury in Australia is really underreported, because especially for young people who are admitted with new respiratory symptoms and no other underlying cause that's been found. It just hasn't been labelled as vaping-related lung injury.
Yes, it's a frightening prospect to think what we might be dealing with in a decade or 3.
Yeah.
Interesting to reflect on this. It must be kind of an eternal frustration for you both, investing your careers into this work. You're observing how much funding's going into all these efforts to stop smoking and vaping, and yet the access to these very, very harmful products is so free, really. And, on the one hand, young people are able to access vapes and we can free to access cigarettes. I know they're expensive now, but they're still very available. And all this work's been done to try to stop people doing it. And it's a real push me, pull you, isn't it? So I guess that while that's the case, we applaud your work, and I'd like to thank you very much for coming along and informing our supervisors, who will, I'm sure, take some of this away and use it in their own practice, but will hopefully educate the next raft of general practitioners to help drive down those rates in our communities. And one day we might be smoke-free, who knows?
That'd be great. That'd be amazing. Thanks very much for the opportunity, Simon. Thanks for coming, everyone.
Thank you very much. It's been great. All the best. Bye-bye.
Okay, thank you. Bye-bye.
Thanks for watching. We'd love your feedback. Please comment or subscribe to our YouTube channel for updates on new videos. If you'd like to ask a question or suggest a topic, you can contact us via our website at gpsa.org.au. GP Supervision Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.